want to officially welcome all of you to the 16th Annual Diabetes Forum. And once again, we have brought together an incredible group of top thinkers and researchers to share their years of experience and knowledge with all of us about what's happening in the world of diabetes and all the advancements that we've seen quite a bit in the last couple of years, and especially at this meeting. My name's Steve Edelman. I'm the founder and director of Taking Control of Your Diabetes. And first things first is I need to introduce my long-term good friend and colleague, Kelly Close.
You have been an amazing friend to diaTribe. Way back in 2006, diaTribe was all about making people smarter about diabetes and prediabetes and advocating for action. That's what it was about then, and that's what it was about. It's what it's about today. We're all about making sense of diabetes and giving people tools and information to lead their very best lives.
Let me tell you a few things about TCOYD. We will introduce our esteemed panel and thank our sponsors. This is a picture of the brochure of our first TCOYD conference in 1995, really to educate, motivate, and push people into self-advocacy. It's all about motivation. And we have awesome programs. You can see we've done over 50 programs since COVID came along with 1.1 million views. And some of you have seen our stuff. We try to make it entertaining. Okay, Kelly.
So we're going to start with a huge thank you to the most generous, best-in-class sponsors, AstraZeneca and Dexcom. And AstraZeneca, as you know, is really at the forefront of just groundbreaking therapies for people with type 2 diabetes, with drugs that not only aid in glycemic management, but that are really, really working to reduce cardiovascular disease, that are working to reduce CKD, and are really also on the forefront of prompting heart health and kidney health.
Yeah, and thanks to Dexcom, who have innovated CGM technology and has really driven AID systems. And you can imagine that, I think it's the next standard of care, or it could be right now for people with type 1, and we appreciate their support.
We want to thank our first-in-class sponsors. Let's see if this is all moving right. Lilly Diabetes and Vertex, who are just doing groundbreaking work, helping people living with diabetes.
We want to thank Tandem and Xeris for also being our sustaining sponsors, as well as multiple other countries who did contribute to the diaTribe and TCOYD Diabetes Forum. And we appreciate every bit of support. It goes a long way, and it allows us to reach as many healthcare professionals and patients as we possibly can. So thank you very much.
Now we get to bring out our extraordinary panelists and ask them to come to the stage and join us.
Come on up.
We're going to introduce them as they come up. And first we have Dr. James Gavin, who's a truly renowned medical expert, CEO and Chief Medical Officer of Healing Our Village. And, in addition to being a clinical professor of medicine at Emory and at Indiana University School of Medicine, everyone here knows him as a trailblazer, scientist, advocate, mentor, educator for diabetes, and a dear friend to so very, very many of us in the room. Dr. Gavin.
Yes. Jim has been on the panel many years. We really appreciate it. Jim is just an amazing individual, and I'll leave it at that. You can learn from his wisdom as we go through. So I'd like to introduce Jeremy Pettis, who I've known for 10 years. And has become a close friend and colleague, and I do believe he'll make a big mark in diabetes care for the next couple of decades. He developed type 1 when he was 15 years old and has dedicated his career to helping and taking care of patients, but he has also made a mark in research. So he has put a lot of effort into adjunctive therapies, bringing to the forefront insulin resistance in cardiovascular disease in type 1 diabetes, and really does a lot of research on the prevention, preservation, and replacement of beta cells. So it's my pleasure to introduce Jeremy, and thank you for being on the panel.
Thanks, Steve. Happy to be here.
And tonight, a special rising star in diabetes, Dr. Leslie Eiland. She understands diabetes firsthand. She has diabetes. She lives with it. She is so committed through every part of her life. Research, being a clinical star, helping mentor others, other rising stars in the field, other emerging leaders. She's at University of Nebraska Medical Center. I love it that she's a fellow in Nebraska, and we really had to fight over who got to introduce you, Leslie. Medical director in endocrine telehealth program. She knew working on telehealth way, way, way before the pandemic started, and we all are going to be looking to her for wisdom tonight on this and many other fronts.
Yes. Well, it's my distinct pleasure to introduce my long-term friend and colleague, Dr. Bill Polonsky, and cycling partner. He has distinguished himself as really a national and international leader in the emotional and behavioral issues around diabetes. He's the founder and president of the Behavioral Diabetes Institute, as well as a professor at UCSD, where he shares his wisdom with our residents and fellows. And he has helped countless individuals and their loved ones dealing with diabetes. We know that's an important issue, something that Kelly and diaTribe also focus on. And Bill is the founding recipient of a special award called the Honorary Diabetes Degree. And this award is given to individuals who really knows what it's like to live with diabetes, but does not have diabetes himself or herself. And it's only been given to 3 people. He was the first recipient. So he's quite a special individual.
And finally, Dr. Carol Wisham, absolute star, Spokane, Washington. I think you're in your last week, right? In the last couple of weeks of being 1 week of president of Endo, the amazing things that you can make happen while you're doing all of your other work, all of your research, watching you do so much work on tirzepatide, so much work on the groundbreaking therapies and technologies that we have watched together over the last couple of decades. And your commitment to us is just profound. So, you're active in many, many organizations, and we're going to have a really fun time talking to you about those tonight.
So Kelly, I'm going to give the ground rules to the panelists. I know they don't read my emails too closely, but we have a lot of good questions to cover. We're going to address our questions to one of the panelists, and the others are totally free to jump in, because it's not just a one expert answer. And we just want to keep these responses short and terse. And the reason why we're being blinded by these lights, because this event actually is part of a asynchronous hybrid event that approximately 1 month from now, we're going to have this on a virtual platform and then advertise to the masses that could not make it to this conference, including people with diabetes. So Kelly, please, you can start.
Excellent. So Jim, we're going to start with you, and we're going to talk about standards of care, right? So, and how amazing is the ADA to be having a living standards of care? I know that you had a lot to do with that back in the day when Cephalou thought of it in the first place. What can you tell us? What are the most important things for people to learn about standards of care changes in, heart failure, kidney disease, the different therapies and technologies, and what do you want to see?
Well, for this answer, the standards of care this year, is a 270-page document. Oh. So this one won't be so short and so terse, but I'll try to do my best. So when I think about it, for the standards of care this year, the most significant changes that have occurred in those guidelines are the recommendations that seek to really direct providers to use guideline-directed therapy for more individualized treatment. Now, I'm going to point out one example of that as a demonstration point, and that's the recommendation to refer adults who are overweight or obese and who are at high risk for type 2 diabetes, like the people who were in the DPP program, to refer those people to intensive lifestyle change programs for behavioral changes that could result in the 7% or so weight loss required to prevent them from going on to diabetes. Now, those are the kinds of recommendations that really represent the specific, prescriptive, but flexible recommendations, coupled with the tools that can actually operationalize those recommendations. We have in that same standard the diabetes risk test, for example. We have now the standardization of A1C levels, and hopefully in the future we'll be advancing things like how do we use CGM for making these kinds of determinations, and they will make their way into the standards. Now, this kind of focus on individualization of care is more evident in the recommendations that have emerged for providers to evaluate all of their patients with diabetes for ASCVD, for risk factors, for cardiovascular disease, for chronic kidney disease. And not only are they advised to evaluate them, but the tools for operationalizing interventions to interrupt those high-risk states are now being centered upon. Now, we have a patient-centered glycemic management thrust. I think it ought to be called a patient-centered cardiometabolic management scheme, because we're moving away from that glucose-centric model of care. And the guidelines actually clearly indicate that. The tools are there to operationalize all of the recommendations that are being made about ASCVD, about chronic kidney disease, and about heart failure. We can operationalize the recommendations and interrupt the cycle of the outcomes that are so common among people with type 2 diabetes. So I'm going to leave it at that, because I know that there are others who want to weigh in. I see it by the look in their eye.
That
I
gleam.
just want to tell people,
It should
I
be
just
on.
want to tell people,
Get a green
Is
light.
that working?
Just speak closer to it, maybe.
No, you got to
it's
get a
not, I
green
don't have
light.
green.
Oh, I
I got
see.
the bad mic. I just want to tell people the first standards of care were published in 1985. They were 4 pages. And I remember them because I had just started my clinical practice at that time. Don't do your fingers. And I thought trying to get somebody's A1C below, I think it was 8% at the time, was, oh my God, that's impossible. I don't have the tools to do that. So it just tells you how far things have come over the years.
And I give the ADA credit for making it a living document, because there's so many advances coming out. And I think the other thing that these guidelines have done is based on the recommendations of people with atherosclerotic cardiovascular disease and renal disease and heart failure, that it really has created a lot more communication between endocrinologists, cardiologists, and nephrologists. And I've never seen it like this in the past.
So let me just comment on that, Steve, because I do think that now that, and if you go to the guidelines, you'll see that we are all using common tools to address the management of common chronic complications in our patients. Endocrinologists, cardiologists, and nephrologists. We have a common toolkit now. We are speaking a common narrative in terms of things and strategies that we want to employ. I'm wondering whether or not we're moving in the direction of developing common sets of guidelines, whether there's an opportunity here to have a joint panel for guidelines development across those disciplines.
So
Cardiologists be flexible and with us?
So
I don't think so.
So the ACC has already endorsed the ADA recommendations for management of patients with cardiovascular disease, and they're trying to get nephrology on board for the next series. So that's already happening.
Okay, well, let's go on to the next topic. You know, you may have heard of this drug at the conference. I'm not sure. Tirzepatide, maybe. And, you know, I know Carol has been involved in the clinical research of it, and she's very much on this topic. I'm sure some of our other panelists may want to weigh in, but say anything you like about tirzepatide and its implications towards treating everything from kidney and heart disease to NASH and obstructive sleep apnea.
Yeah, so very good. So a couple of things. First of all, I don't think any of you missed the fact that obesity as a treatment, as a primary endpoint for treatment of patients with diabetes is being put front and center. In fact, I listened to the new glycemic recommendations that are going to come out of the ADA ESD before coming here, and they are recommending weight first. So tirzepatide offers the opportunity for us to reach bariatric surgery level weight loss, at least in patients without diabetes, somewhat less in the patients with diabetes, but still 50% of patients were able to lose more than 15% of weight loss. That's the threshold at which all of the things that you just mentioned, NASH, sleep apnea, probably improvement in chronic kidney disease, all are going to happen just on the basis of weight loss alone. And then there's all the benefits of the GLP-1 receptor agonists that we anticipate will carry through and show us even better benefits from cardiovascular disease.
You know, Jeremy, I don't know if you heard or I know you're involved in it, but tirzepatide, some of the research program in type 1 diabetes. What do you think about that?
Yeah, I can talk about kind of adjunctive therapies.
Why don't we go? Jerry's going to talk about adjunctive therapies. He always tells me what to do. I mean, older drugs like SGLT2s and GLP-1s, but now we got GRAs and a whole slew of others, and that's been one of his areas of interest.
Yeah, well, first of all, I got to say they gave me my rock wig to wear up here, but I didn't think anybody would take me seriously, and it's very, very hot. So I'm going to and Steve has his too, and he didn't wear his. So, so this is probably the topic I'll say the most about, and then I'll be quiet. So I agree, obviously, of course, with everything that Jim said, that we're speaking a common language in terms of cardiometabolic health, except when it comes to type 1 diabetes. That type 1s are completely left out of this conversation with the advances of GLP-1s and SGLT2s. And I always joke with Steve that I'm jealous of type 2s with all these medications. But the truth is I'm upset about it, that there's really a role for these quote unquote adjunct therapies in type 1 to go beyond glycemic control, to improve cardiometabolic health. And part of the problem is literally the definition that we use. We call them adjunctive therapies. And not to be totally cliche, but I went to Webster's dictionary and I looked up the term adjunctive, and it is, quote, added to something else as a supplement rather than an essential part. So to call something adjunctive automatically puts it in a place of less than or not important. But I think these therapies are really, again, they can be designed to address these things in type 1 that we're not focusing on.
You should have seen what Urban Dictionary said.
And, you know, to drive that point home, we would never call SGLT2 inhibitors adjuncts to metformin in type 2 diabetes. They're just other therapies that address other metabolic pathways. And that's how I think we should think about these therapies in type 1s, addressing known metabolic pathways and addressing specifically things that insulin cannot. And there's a few things that insulin can't address, and these are important things. So the first is that people with type 1 diabetes universally across the board have insulin resistance. And sometimes it takes people a second to realize that. I'm not talking about type 2s, I'm talking about type 1s. And that predisposes them to cardiovascular disease. And the leading theory is the reason that type 1s have insulin resistance is because since we're diagnosed, we have to take high doses of insulin, and those doses of insulin can induce insulin resistance. So there's an opportunity there to use therapies to reduce insulin requirements to improve cardiovascular disease. And second is that weight gain is a huge problem in type 1s. We know that most type 1s are overweight or obese. This is something that is at least not made better by insulin. It's actually generally made worse. And finally is hypoglycemia, another problem that's not addressed by insulin. So it's another way of saying that I think glucose control is potentially a solvable problem in type 1 diabetes with all these new advances, but we're still left with this cardiometabolic health, which we address in type 2 all the time, but we're not talking about in type 1s. So what can we do? The last things I'll say is a couple things. First, we need to change our mindset of what we would deem success of an adjunctive therapy in type 1. Of course, we want better glucose control, but we need better outcomes of weight loss, improving insulin resistance, cardiovascular outcomes. That's one thing. Second, I think it's beyond time for us to revisit SGLT2s and GLP-1s and type 1 diabetes because the benefits of these drugs are just getting more and more. We now have heard about continuous ketone meters coming out, maybe a way to unlock SGLT2s and type 1s again. And then finally, we have an opportunity for novel targets in type 1s. Glucagon receptor antagonists, you mentioned, glucose kinase activators. There's a company actually working on a dual GLP-1 GIP for type 1s. So I think I hope that this is the next wave of kind of adult type 1 research of taking a page from our type 2 brethren and using it in type 1s. And I'll stop talking.
I'm going to just make an important plea for looking at the MRAs in patients with type 1 diabetes and chronic kidney disease, because there's no reason why their kidney disease is any different from the patient with type 2 diabetes, and they should be able to benefit without any of the adverse effects that we typically see with some of these other agents.
Thanks, Carol.
You know, see, if I could just add, one of the problems, Jeremy, that causes this label of adjunctive therapies to be used in type 1 and not type 2 is because there's this pathophysiologic scheme of the ominous octet or the egregious 11 for type 2 diabetes that points out all of these defects that need to be targeted by therapies, whereas type 1 diabetes suffers from the singularity. That is, if you fix the deficits from the beta cell, and maybe the alpha cell, you'll fix most of the issues. So start working on a scheme.
I've been wanting to write an article called The Ominous Octet of Type 1 Diabetes for the longest time because it exists.
You've just been given permission.
Okay, I'm going to do it.
Yes.
Yeah, and the co-author is going to be Ralph DeFranza.
Well, you've just been given permission, and all of the associates, the close concerns, and all the associates at diaTribe, and all the amazing analysts at dQ&A will help you with that, Jeremy. We know how busy you are.
Yeah.
I'm going to just switch gears on us just for is that cool, Steve?
Please.
Yeah. Okay. So, I mean, how cool was it when is it Dr. Jeffrey Mechanic was one of them, right? And then the other doctor, is it Ildiko?
Ildiko.
Yeah. I mean, that whole thing about, is 15%, 15%, the new 7%. And maybe we just do a lightning round, right? Like yes, no, yes, no, yes, yes, yes. What do you think? Is it, and also Jeremy, the question about bringing this into type 1, I mean, all of us deserve metabolic health, right? Whether or not people have obesity, whether or not people are overweight. So I love you taking us this direction. But is it, are you guys going to be brave enough to ask for what all of your patients deserve? Yeah. And we know you're so behind helping them get that. And how hard will this be? I know a bunch of you can influence the standards of care, so.
I should just add on to what Jeremy was saying about the SGLT2s. We all remember how the FDA turned sotagliflozin down and 2 other SGLT2s. And we both think that if they went to the FDA now, knowing what we know what these drugs do, they probably would have got approved. And I was reading close concerns in my hotel room. Oh. Much more cooler in there, I should say better temperature in there than the convention center across the street. But that one relatively small study of EMPA in type 1s improved time and range over 10% with no ketones showing up in the urine at all. It was a short study. It was a crossover study, but I do think there is promise for sure. Yeah. Okay.
We're gonna
answer your question. The answer is
Thank
yes.
you.
Yes, we are. I think most of us are right there saying we need to do weight as a co-primary. We're not going to throw A1C out, but again, it's still going to be important. But in order how we get there, we know that now. How we get there is important, and so that's just pushing. And now that we have the meds that can actually get there, I think that yes, we're going to be looking at 15%.
Yeah. So cool. And we also love it that you're also all working on safety. And maybe it isn't so glamorous, but many different ways to address euglycemic DKA. It is a real thing. And so it was amazing to see in the headlines this week, work by Abbott being done on CKM, just not have a cool sound, CKM, continuous ketone monitoring. So Bill, we're going to ask you about the once weeklies. So what do you think? I I think the way this question was maybe first given to you, maybe the word adherence was in there. I'm going to talk about engagement instead. But what can you say about engagement? How does engagement change with once weekly insulin, once weekly GLP-1? Talk to us.
I hope you can hear me. I think it brings up a bigger issue, given everything you've just talked about. Something I've devoted a lot of my career to, which is that we have all these wonderful opportunities and new medications available now and new ones coming. And it's actually fascinating to hear Jeremy talk about insulin resistance and type 1. And they don't work very well if people don't take them. So I get to spend most of my time worrying about those issues. And one of the questions that came up, as Kelly mentioned, is like, well, so does it matter if we make it easier for people? So if we switch from once daily to once weekly, do we see people, I'll use the bad word, adherence, are people sticking with their meds? And the answer is, well, there's good news and bad news. The good news is, yeah, it's pretty obvious, right? I mean, if we simply make it easier and more convenient for folks, we just published a big study on this in December, that yes, people on, and we focused on GLP-1s. I'm sure we're going to see the same thing with daily versus weekly insulin. People are more sticking with it. You see persistence much better, well, significantly better on once weekly versus once daily. That's the good news. But here's the bad news. What better means, at 1 year after initiation, the once weekly, we're at about 48% persistent. So again, more than half have already quit. So for once daily, it's worse than that. So yeah, once weekly is better, and that's helping, but it's certainly not solving the problem of the real issue we face in terms of the struggles our patients face in terms of medication adherence or persistence over time, which includes cost, side effects, medication beliefs. And maybe we'll talk about that more, but it's a big issue.
Let me ask Leslie a question. She's very quiet and polite.
Well, I would, to go back to the 15% and to talk about adherence, I think we also need to recognize that access is also an issue. And sometimes your adherence drops off because your insurance changes and your access changes. And I, really struggle with getting a lot of meds that are approved now approved for my patients. And I'm writing letters and I'm doing peer-to-peers on the phone. And I have access at, with an academic medical center to a full-time medication access coordinator. And I still have issues. And until we solve those problems, I don't think there's going to be equitable access to these newer medications.
Yeah, looking at the root source of the problem. Yeah.
Well, and the providers need to prescribe them.
Yeah. Well, Leslie, you're sort of an expert on telemedicine, and you've spoken to professionals at our TCOYD conference, and I'd love to hear your thoughts about what's going on with telemedicine now and after COVID, but also around health equity in telehealth. I know that's one of your areas of interest, and what are some of the models you've seen that have worked? Especially you're in an area where people drive 3 hours just to get to the university there.
So we started our telehealth program in 2013 at the University of Nebraska, and this is clinic-based telehealth. So people are driving 5 minutes up to 2 hours one way just to see myself or one of my partners over a screen at a rural community hospital. It's facilitated by a nurse who's usually lovely and like a community pillar and related to half the town. And it's been a really good model. We have 4 sites in Nebraska and 4 sites in Western Iowa. And when the reimbursement models changed with the public health emergency in the spring of 2020, we really thought that we were going to need to pivot away from this model, because why would anyone come and drive to see me on a screen when they can connect and just see me on a screen at home? It seemed obvious that we would be shuttering these clinics, and we've actually seen growth, like stability and growth in all of these locations. So I think it seems silly now in hindsight that we thought that just a change in reimbursement models would flip the switch and suddenly like everyone would have access to specialty care, but it's just not what we're seeing. And I think if I could summarize how I feel about home visits now, it's just that it's a really convenient way to receive care for the people who are already plugged in and are already receiving care. I don't see the broad increase in access that we hoped, and I think we really underestimated how poor broadband is in this country, and it's not just sort of a black and white, do you have internet, do you not? But we're talking about reliable, high-speed internet at threshold speeds high enough for synchronous video conferencing, and many people do not have access to that. And I think we also underestimated, and because we do this all day, the amount of digital literacy that it takes to have a visit, to get onto a patient portal, to download an app, to launch Zoom from a browser. And it's one thing to connect to your provider, but then to also have a visit that's effective. Then we're asking people to share glucose data. We're asking them to manually upload devices from home, and many people don't have personal computers. We're asking them to connect to a cloud, which requires even a higher amount of digital literacy. So I'm just a little worried now, 2 years in, that I feel like the people who need care are not accessing home visits like we hoped they would be able to. And I think we need to be really careful moving forward that we're not widening already existing disparities.
Well, you said something the other night at dinner that your patients are driving 3 hours to see you face to face. Are those the people that just can't handle the technology? And I can tell you, all of us at UCSD, we have big issues there, you know.
Yeah. Some of it is the technology. Some of it is, I think, people just are yearning for human connection again, and they want to get back to the clinic, and they want to see people. And Kelly knows, maybe from rural Nebraska, that when you come in to Omaha for a visit, I mean, you're doing a lot more than that. You're in a Costco, you're in a Target, you're getting some furniture.
Oh, yeah.
You know, you make
Totally.
a day out of it. And I
Yeah.
do think, you know, for people who have,
Totally.
days off in different buckets with their employers, the draw of having a telehealth visit over 30 minutes during your lunch hour and not having to take time off work. But then if you can get flex time and take a whole day off and come in, you're going to come in. So I think people are motivated by a wide variety of factors. And I'm constantly surprised at the people who I know they can do a home visit. I've had a home visit with them over the last 2 years, but they're choosing to get in the car and spend, an entire day coming in.
But of course, I mean, Leslie, like, we want to see you. I mean, the way you make me feel, and you, Jim, and you, Bill, and you, Carol, every single person out there, Jeremy, Steve, it is the way you make us patients feel like we can do this, So, I mean, I love the stories.
Thanks.
In Omaha. It was a big city. It was where we bought the New York Times every 6 months, when I was little. But it's way more than that. But the amount of time that also all of you are spending, the workflow, all of that, there have got to be big minds on that out here. The other pieces, I feel like as a patient, I have heard now for over 2 years about how bad broadband is. Like, who is it? What industry is it? And can it be diabetes first that really actually crystallizes this problem and what is needed and then makes it happen?
Yeah.
I do think there are a couple solutions that I'm excited about, and I hope people invest some resources in it. I think we should be doing more telehealth in libraries. Libraries are
really cool.
Trusted community resources. They have space. They're trying to reinvent themselves. They're utilizing more digital resources. Fewer people are coming in. They have free internet. They have the space. We could throw a computer and a scale in, and librarians are trained to help people access information in a kind, patient way, which I think it could be a really good fit, and it mitigates a lot of the access issues that we've discussed. And then there's also something called Digital Navigators. There's a nonprofit called digitalinclusion.org, which is training people similar to a role of a community health worker, where you can work with people one-on-one and understand their individual issues around digital access, whether that's literacy training or whether that's getting them to a nearby library or community center where there is stable internet, and working with them individually based on the resources available in their community.
And some of that is that some of what the Navigators do, and you'll help me with this, Jim and Leslie and all of you, is the Digital Navigators. And we got to interview Earl's Digital Navigator, and it will be coming out soon we hope across our different publications. But you'll help us with this. Is it all about the technology? Is it also about the access? What are the things in your vision that could make all of you and all of them and every clinician be working at the highest end of their game?
I mean, I think it's a mix. I think it's helping people fill out paperwork to get the federal subsidy for broadband, that additional stipend. I think it's connecting them, like taking them through, maybe sitting with them and going through like a webinar on how to download Zoom, how to download an app.
And we get it, like all the digital pieces. And are they also helping, like you guys, with the paperwork and all of that? I mean, I don't know.
That would be
I
nice,
think it's part of maybe what Dr. Earl Hirsch's Navigator does. But we're gonna keep moving and go to remission. Oh, but please,
Could I,
please,
if I
Jim,
could just
yes.
add one other suggestion, because I like the notion of the library as a resource for this, but there are other communities where a stable institution that could serve as that kind of resource could be the church.
Chick-fil-A.
Yes.
Chick-fil-A closes on Sundays. You know, and you have people who are there as a stable institution, and you can actually use this as a source of education that's an ongoing source of education. So it's another piece to add. What we need, though, is a model, something that can serve as a template, because diabetes may, in fact, be the case study, but it's the kind of thing that is going to be needed for other kinds of interventions as well.
You know, Leslie, when you mentioned libraries, I think in San Diego, most of them have gone away during COVID, and now I believe they're starting to come back, but I felt like they're a thing of the past now. So
Gone away, Steve. You
No,
just
they're
haven't been to one.
community-based organizations. We love it.
YMCA.
My first job
just-
was at a public library, St. Paul Public Library. But we want to know about remission. Kind of, we've heard remission being tossed around back and forth with T2D even more frequently lately. What does that mean to you? Starting with Bill.
reversal too. Jim,
Yes,
what do you
remission
think?
and reversal.
The word reversal and remission.
Well,
What is-
let me just take on remission, because I think this is a pretty exciting and concept in the diabetes space, because it refers to a situation where a person with diagnosed diabetes actually reverts to a condition of normal or near normal glycemia without the benefit of glucose lowering medicines for a period of time. Now, the process is different for type 1 and type 2 diabetes. In type 1 diabetes, it really describes a situation where fairly early in the course of a person's disease, they actually are able to go off of insulin and remain off of insulin with near normal levels of glucose. But the fact of the matter is, it usually is in the very early part and doesn't last for very long. They've done cyclosporin interventions with immunosuppressants, but again, after 2 years, most of the people require insulin at the same level as the non-treated people. One case study that I'm aware of, 7 years after cyclosporin, they were still in remission, but that was a person who was a well-conditioned athlete, and it was thought that it was as much as insulin sensitivity as it was his beta cell improvement that accounted for that. So it's a little fuzzy situation with respect to remission. It's not a cure, and that's the thing we have to really be careful about. And it's not reversal of diabetes. Right. It's really a pause, if you will, and it's of indeterminate duration.
So yeah, I like to tell my patients that, you know, a lot of cancers go into remission, but you don't know if they're cured for many years, and so they should assume that if they go into remission that they need to continue to monitor closely, because they could come back after bariatric surgery. But what I think is that we need to all, as clinicians, have either in our own offices or referral centers that we can refer our patients with newly diagnosed diabetes if they're interested, so that they can go on the really low-calorie diet, total meal replacement type diet that was demonstrated in the direct study to be associated. And again, it was that 15% was that cutoff, that threshold where the vast majority of patients went into remission.
That was so cool to see all of that work by Roy Taylor in the UK. I mean, from a behavior perspective, Bill, though, like, do you think that excites people more and it can get people even more energized about food, exercise, mindset, and sleep. The idea of remission or reversal, like what, I mean, I don't know, like I know from the perspective of drugs that help prevent complications, that did not exist, even just a few years ago. So what would you say about what you hear from people with diabetes on that?
I didn't know if you were talking to me, but I'll
Yeah.
respond anyway.
Yes, I am.
So I think, I hope this is true of everyone in this room. We're all, for my entire career, we're really humbled in the face of trying to help people or ourselves manage our weight successfully. And I think it's important to remember that. And we do see these amazing things happen, and the DIRECT study is a perfect example of that. And even in the Look Ahead trial, there's this hardcore group of about 20% of folks who lost at least 10% of their body weight, kept it off over the course of many, many years. And I don't know how they did that. And it remains humbling. What's exciting, of course, is that we do have all these extraordinary drugs that can make an enormous difference and are going to help a much larger swath of people to be successful. And in my bones, I'm sorry that we have to even think about how valuable these drugs are going to be. I think, like so many of us, we wish this could be just simple lifestyle changes that people could be successful, and it hasn't happened. I don't think it's going to. So thank goodness for all these drugs.
You can't fight the biology. That's
No.
the problem.
Yeah.
There's what I see out there is there's some good programs out there that talk about reversal, remission. Bill, I'd be interested to hear what you think, what patients really hear when they hear the word remission. It might be thinking that a lot of them think that they're cured, but there's some good programs out there, and there's also some shisty ones, that will invite patients to dinner and promise them to get off their medications, and that's such a bad message, So
Well, I think the most important thing to remember about any programs that you're become attracted to is that actually it's not that difficult to help people lose weight and keep it off for about 6 months, but then it gets difficult. And so, we always want to pay attention to studies that are looking at maintained efforts over the course of at least 12 months, and well beyond that is what's important. And it just remains, it's a humbling challenge.
Jim, did you have a comment?
Well, I think one of the problems that we have is the notion of remission as it is presently defined in type 2 diabetes, for example, is very fuzzy. It depends on how early you intervene. If you intervene very early, and it's a matter of how much weight you get off. The more weight you get off, the longer you have remission, and the higher the remission rate. And again, the definition is fuzzy, because one group says that remission is the achievement of an A1C of less than 6.5 on no meds for at least 2 months. Another group says it's the achievement of an A1C of less than 5.7 on no meds for at least 1 year. And then the least stringent definition is an A1C of less than 6.5, but you can stay on metformin as long as you get rid of all of your other medications. I think we should just split the difference. If you can take one medicine, okay, and still get to an A1C of less than 6.5 and stay there for a year or more, then maybe we should be agnostic of what that medicine is. You can stay on that medicine, meet those criteria, you're in remission, and everybody is happy.
Yeah, some of those medicines are being taken for cardiovascular disease reduction and kidney disease
That's
reduction.
a good thing, because you can
not
cover
for
yourself.
Glycemia,
Yeah, that's
right. And while you're at it, you also could try to work to persuade and engage FDA, maybe work with diaTribe on this to get metformin approved for pre-diabetes. So that wouldn't even have to be a thing.
Yeah. Good move.
Steve.
Well, okay. Well, let's ask Carol a question. I asked Carol previously if she could give us a CGM update. We had the Libre 3 was approved, the G7's on the way. Eversense is now approved for 6 months with future advances. And Carol's got a lot of experience from her clinic in Spokane, Washington.
Better sensors coming.
I'm
from
humbled to be
Europe.
answering this question because I'm sitting around people who probably are more sophisticated in their knowledge about CGM, but I have a vast majority of my patients with type 1 and type 2 diabetes are on CGM and incredibly interested in the new updates. So the Libre 3, as you know, is approved. They describe it as 2 pennies instead of 2 quarters in terms of size. Has an improved, accuracy, particularly at the low end, and will automatically be sent to your phone. So no more reason to scan. What I did learn today is that if any of patients need the actual reader, such as what they use for the Libre 2, they're going to need to stick with the Libre 2 because this is only going to be available as a phone app. So that, I think, is going to be exciting. It's going to be really nice for especially our younger, perhaps, female population that doesn't want to have that, large thing on their arm that's so obvious. But the Libre 2 is going to remain a very important part of our care. The Dexcom, as you know, the G7 should be approved. I expect to hear about that any day. In fact, I thought we might hear about it this meeting. And as you know, that is now a fully disposable, incredibly small sensor, easier application, improved accuracy as well. And it's still a 10-day, but I think that they've got some improvement in the apps that probably aren't going to make a huge difference in terms of our patients. And then the Eversense, I've been waiting. A lot of my patients are just kind of on board waiting for that 180-day approval, so we're just waiting for it to be available. And somebody may have to learn how to insert them because I lost my PA that was doing it.
Yeah. Well, the Eversense, it's available, and finding good inserter, I think that's important. With the Dexcom, it's also got a 30-minute warm-up period.
That's right. Forgot.
And a 12-hour grace period after the 10 days. And for us users, it's very nice to have that from patients and things like that. Well, and I think, with the Libre, the Abbott folks are waiting to solve the vitamin C issue with interference with a true glucose value, and then they'll be able to integrate with insulin pumps. And Eversense folks will as well, as they're working on that, and also working on the 365. Bill, you've done a lot of work in CGM and behavior change, and some of the studies I've read, may not have shown a greater difference as I would have thought, and others do. Tell us your thoughts on that, and how has CGM affected the world of, how behavior has affected success or not success on a CGM.
Well, it depends what kind of outcomes you want to talk about. Can you hear me? Yes.
Get closer.
I'm happy to get closer. So, as many of you know, we see CGM as a motivational tool. It's a behavior change tool. I mean, this has changed everything, and not just people with type 1 and not just insulin users, but as it becomes more accessible to, everyone, this is something that people take as a tool that they can, it becomes something as not a punishment, it's not a critique, like how is my blood sugar high or low, but it becomes their tool. It's something that they can use. And the studies, though, if you're speaking about like patient-reported outcomes, we wrote a review about that a couple years ago, have actually been surprisingly limited in terms of what we've seen. And certainly the biggest impact has been on helping people feel less concerned and fearful about hypoglycemia, helping them feel more confident that they can be safe. That's been pretty consistent. And one of my big interests has to do with helping and addressing this very common issue of fear of hypoglycemia. And CGM is one of the most important tools to help people actually, as we say, be safe, but it isn't enough to help people feel safe. So we actually are introducing other strategies on top of that, which we use with CGM that can make, we hope, as we develop more studies, that can make a really big difference. I don't know what else to say about that. I can talk forever about that.
No, I appreciate that. But my opinion is, and we've talked about this, it really depends on the protocol. And if patients are taught to look at the CGM, look at the trend arrows, look at their behavior, and that makes a big difference. First, you can't just give someone with type 2 a CGM, slap it on for the most part, and just say, come back as part of a study and expect major changes. In a few individuals, for sure. So it's part of the protocol design.
Well, yeah. I mean, sometimes I'm going to be excited to hear what you guys think about AID over time. I mean, to see many people with type 2 actually benefiting massively from AID as long as the rest of the system is particularly easy. And I see strides all over the place there. So I'd love to hear, Jeremy, as we move, we want to hear first what you think about AID, and then we're going to move into also talking about just prevention and delay in early stage 1 and stage 2 diabetes as well. But just this piece on hypoglycemia, because you have so much experience as a person with diabetes yourself.
Well, let me answer the last thing first.
Okay.
And we can talk about AID, which is a huge topic. And there's been so many advances in automated insulin delivery.
Yeah.
But, talking about broadly cure-based therapies in type 1 diabetes. And, Steve and I were always talking that before the pandemic, when we did our TCOYD conferences in person, we would always end the day, this is, 3 years ago, 4 years ago, talking about, what's on the horizon for the cure in type 1 diabetes. And I hated doing that talk because I just felt like there just wasn't that much to like concrete things to tell people. And it kind of ended on a downer. And now we could talk for hours about, like what's going on, which is really, really exciting. So let's start with, prevention, if you will, of type 1 diabetes. And to be on the cusp of now teplizumab, prevention bios drug, potentially being approved in August as the first disease-modifying agent in type 1 diabetes is huge. And, the clinical data showing that a 14-day course of this drug can prevent the onset of type 1 diabetes on average by 3 years is a great place to be at. And when, we were on the original, FDA panel meeting, people said, was that really a big deal? And I just wanted to strangle them, because I'm thinking, I have little kids, everybody that has, kids, the difference between having a kid diagnosed when they're 5 versus 8. I mean, think about, the less shots and the time for their mental development, not to mention everything that, is going on in the world of diabetes, that 3-year delay is a big deal. And there's people in the clinical trial that still haven't gotten type 1. So this is a great place that, again, starting in August, we could have this drug approved, and then we build from there. We add on other therapies. Can we do it in new onset? Like we've really, this is opening the door to this whole new area of therapeutics is fantastic. And what we're going to see is really a change in public health. Because to identify people with type 1 diabetes that are at risk, we need to check autoantibodies. And do we start doing routine screening? How do we get people referred? How do we get them, if they're positive, and to see an endocrinologist to get these medications? It's going to herald a needed change in type 1 diabetes treatment. And actually to remind us all that we've just been treating the symptoms for decades. CGM, insulin, this is all great things, but they don't change the disease itself. And here we are reminded this is an autoimmune disease, and we have for the first time a therapy that can actually do something about it is fantastic. So that's prevention. In terms of preservation, you're just diagnosed with type 1. What can I do to, maintain my remaining beta cells? A lot of work going on in that area. Dompe is a company working on an oral, therapy to preserve beta cells. I'm still a believer in GLP-1s actually in this space. Novo's had some positive data showing that this can potentially preserve C-peptide production. And then, of course, for us old timers like Steve and I guess Leslie and I with type 1 diabetes, meaning old timers, meaning we don't have any beta cells.
Don't forget Kelly.
And Kelly, sorry. I'm apologizing for not calling you an old timer. Meaning, the immune system's run its course. We don't have any beta cells. We need beta cell replacement. And that has been a huge boon. I mean, obviously, a lot of data coming out now with ViaCyte and Vertex. And, we were the first site at UCSD to do ViaCyte implants back in 2014. And it was total science fiction then. You had these stem cells and you could encapsulate them and implant them in patients. And here we are, 8 years later, making huge advances. And Vertex obviously releasing data with their, kind of naked infusion of getting insulin independence. And now they're working on encapsulated approaches. So I'm happy to see multiple, approaches to this of a potential, quote unquote, cure for type 1 diabetes. So there really is so much going on. And as much as I, harped on adjunctive therapies being the next wave, which I really think they are going to be, we really are on the cusp of learning more about cellular replacement therapies, who they're for, encapsulated versus not, reminding ourselves about, infusions of immunological drugs. So it's the sky's the limit for type 1 kind of cure.
Vertex. Go ahead, Jim.
I'm just going to ask Jeremy, are the late stage type 2s who are going to be sort of at the end of their beta cells going to be able to join the queue as well?
We'll worry about them next.
So, the issue with them is weight and the number of cells they need. And so there's probably going to have to go into the queue, like he said.
Well, you just got through telling me that you just pop them with a little bit of
Tirzepatide plus the other.
We got the tools.
There you go.
Yeah. Well, both Vertex and Viasat are using CRISPR technology to help their device not be attacked by autoantibodies. And I don't know if you know where CRISPR got their name. They have a special DNA technology to make vitamins, vegetables CRISPR. And then they brought that over into the biotech world. I'm just kidding.
I was going to say,
but
that's
it
not
sounded,
what I read.
It sounded perfect to me. Well, listen, for all of us folks with diabetes for a long time, Kelly and Jeremy and I and Leslie, I wanted Leslie to cover her opinion of the updates of the AID world. And there was lots of data on AID and type 2 diabetes, by the way, based on our previous conversation. So Leslie does a lot of this stuff. So please tell us your opinions.
Yeah, I think it's really exciting. So Omnipod 5 is now available and increasing their rollout, which I think will be great. Control-IQ is making a tweak later this summer that you can bolus through your phone app, which is nice. Medtronic is making some tweaks to their system and I think improving the patient experience there. When I, have patients on hybrid closed-loop therapy, the visits are shifting a little bit. I think we're making a lot fewer little minutia tweaks to little basal rates. I mean, people are doing really well. And so I think the topics of my visits have changed a bit. And we're talking more about the advanced features of the system, exercise mode, sleep mode, temp target. Are you utilizing them? How are they working? Could we optimize that? And then I spend a ton of time, maybe too much, really trying to help people plan for when their warranty expires, because I think just 4 to 5 years is a really long time. And I want my patients to be really excited about the systems that they're choosing and understand why they're choosing them. And so we spend a lot of time talking about what they like about their system, what's going well, what they may not like about their system, and if what they don't like about their system is available in a different system, then we're starting to talk about what that might look like. Working with our certified diabetes education team to help them look at the physical product and see if that would be a good fit. And so I'm finding that I'm doing more planning for the future than I ever did, because I really want people to feel good about what's a pretty long-term decision.
Can I just say, I'm really interested in hearing about Leslie's life, because on the one hand, she has these very sophisticated patients that gets to talk about these, the newest technology and how it works and tweaking things. And 2 minutes ago, she's talking about getting broadband for some of her rural patients and digital literacy. It's like, I don't know how you bounce back and forth.
It is all. Yeah.
I have fantastic nurses in rural Nebraska that know about all of this, and they know about the technology, and they're like a perfect go-between between myself at an academic medical center and our patients in these small communities.
I would just say that, I'll just say real quickly, Carol, that, when you look at data from the InRange study, they took interested patients, they put them on the best second generation basal. They're already on faster acting analogs, but no CGM. And they had investigators that were diabetes savvy. The best they can do is about 52% time in range. You add in CGM that does not communicate with a pump or someone that's using MDI, and you get to about 65 to 72%, and well, I should say 62%, 65. And then you look at the studies coming out with AID, you're consistently in the 70% range. And I see that in practice. And I think there's a certain amount of AID systems where the patient has to put in a certain amount of effort. You can't just slap these things on. And I've seen patients do horribly on AID systems. Carol, please.
So a couple of things. First of all, studies have shown that a person, even if they're not taking their shots or bolusing with a non-AID system, still will do better on the AID system because it will do something to correct them. So I think we've have to change our paradigm of who's the appropriate candidate for AID. And then the second is I am making a plea for any of those people out there who have these systems. We need to see these in older patients. We have a ton of patients with type 1 diabetes who are in their 60s and 70s and 80s, and we all know that on average, especially those that were diagnosed in the 70s or 60s and before, they age faster, and so they're starting to have some of the geriatric issues earlier. And we need to have data to know what and when and how we make a change in that population.
It's good news we're getting older, right?
Oh, it's great news that we're getting older.
Well,
Yeah.
Jeremy, based on Carol's comment about the AID systems and who are they for, you should mention a few things about Beta Bionics, your experience being a clinical investigator. I know there's a difference between someone that's already doing extremely well on AID who volunteers for the study versus someone that Carol mentioned that may not be into their diabetes as much.
Yeah, I think, we've been hearing about Beta Bionics and the iLet for a while now, and finally getting clinical trial data showing that, the system works. And the big benefit of it is that it's, more qualitative in terms of bolusing when you don't have to announce meals, but if you do, you can say it's a typical meal or a little bit less than typical or more than typical, and moving away from the I'm eating 18.7 grams of carbs, which I have no idea how to count carbs, to be honest. It's hard for everybody. But I will say, surprisingly, some of the good news about it is that, again, we've been hearing about it for a long time. And I remember, 10 years ago, the first time hearing about it. And again, it seemed like pie in the sky. And now things have caught up, which I think is good news, meaning that we have competition. There's Tandem, there's the Omnipod, there's the iLet. They're all going to be, used for potentially different people. And it's just becoming the standard of care. The way that we used to pick pumps, 5 years ago, do you want a patch pump or do you want a tubing? Now we're doing those same kind of choices, but they all have automated, insulin delivery features. And people generally just do better on these systems. They've been a huge boon, and not just for glycemic control, but people are sleeping better. Steve, we talk about this all the time, like less alerts and, lows in the middle of the night, and just waking up with a good blood sugar. I just feel like I'm generally a happy person. Happier, I should say, being on one of these systems. So this is not fringe technology. This is the way that this is going to, kind of keep going. And I think, again, 5 years ago, you asked me, should somebody be on a pump or shots? Whatever they want to do, that's fine with me. Now I'm really saying there's things that these systems can do that you just simply cannot do without shots. And it's sooner or later patients are going to have to get on board with this because it's such a great way to control blood sugars.
Can I just highlight one of the things you're saying, which is, we're finally starting to see quality of life data with these systems. And there's some that's already out. We're going to be seeing a lot more in the next few months, that it isn't just helping people have better glycemic control. It's really changing people's lives. I mean, our patients are telling us, and the data is showing us, people are feeling safer, freer, more well beyond just even sleeping better, right? I mean, this is extraordinary, and I'm looking forward to more and more about that.
That's why Bill is the honorary diabetes degree right there. Thanks, Bill.
Yeah, I mean, it is amazing for those of us lucky enough to have now soft landings, not having fear of severe hypoglycemia because we don't have nearly as much severe hypoglycemia, and so not the corresponding highs. That is massive. And it isn't everyone, and so many other things fall into that. Jim, you have done so much work since the beginning of time on health equity, on social determinants of health. This ADA was incredible on looking at the research on this front. Many of us have gone to visit the Whitney Plantation as an example here in and around New Orleans, like getting a much better sense of what is driving those. Can you tell us more about that and how you're feeling about it this moment with all of the wind behind you?
This is an interesting takeoff at this point in the discussion, because as you talk about the developments in technology and AID and the potential for the impact on quality of life and outcomes and better control, we are still running the risk of speaking for more than one world, because there are many people in our population that won't have that kind of access. And when we talk about the social determinants of health, and that's been a recurrent theme in this meeting, and I'm pleased to see that, because when we talk about what that universe of issues looks like in the social determinants of health, we're really talking about things that encompass economic stability. There's less access to wealth. The wealth gap drives the health gap. There is a problem with socioeconomic position. These are more often disempowered people who don't have much in the way of stature. There's poor health access, there's housing insecurity, there's food insecurity. There's a whole range of issues that have important influence on their response to interventions, even when they have access to interventions, let alone getting that access. Now, as important as these factors are, they are not routinely included among the inclusion criteria of clinical trials. We don't even think about them in our assessment of real-world evaluations of various interventions that either work well or work poorly. And this is the fact, that the social determinants of health account for 50 to 60% of health outcomes. 50 to 60%. So that all of the other stuff we're talking about, the technology, the drugs, and the newer interventions, and this is an important elephant in the room that we have to address, and we're beginning to, but the fact of the matter is it involves the embrace of some very uncomfortable truths. Because the social determinants of health are not accidental, they're not incidental, they are the result of structures and histories that have been lived. And if we don't embrace that, if we don't start at that embrace and that understanding, then we don't forge a way forward that's going to be meaningful or credible. And it'll take longer than we have tonight to really do a deep dive on the social determinants of health. I'll just say the model that I would say in terms of what to do about them is the model that I use is that it's a big, ugly elephant, okay, that we have to eat a bite at a time. Okay, there are some companies here, for example, that have started initiatives that increase education, increase awareness, that make their products more available to marginalized populations. You know, that's taking a bite out of the elephant. There are programs that are trying to increase the traffic of underrepresented, marginalized populations into medical education, healthcare, leadership opportunities, faculty programs. That's not quick, it's not easy, but that's one of the ways to take a bite out of the elephant. And the only thing I would end by saying that denial is not a good starting place to build strength going forward, okay? And it sure won't take any chunks out of our elephant, so.
Yeah, I mean, join us.
Well,
I think you're saying like
what-
hope
there's-
is not a strategy.
No.
Thank you, Jim, for that. That's kind of
Thank
a
you.
very strong way to finish our panel. We have more questions, but I think now's a good place to stop. I would say most of our panel can stay for a little bit, so you can go up and say hi to them afterwards. But if there's any dying questions, someone dying to ask a question, please,
Don't die, yeah. We don't
please go to the mic and we can answer just a few, and we'll try to answer them briefly.
And in the meantime, Steve and I just want to
Please.
say so many big thanks also to our teams for doing so much to put tonight on. diaTribe at TCOYD. My team's also at Close Concerns, and dQ&A has helped all of us think about the data and really zone in on what we need to call out as change. Do we see anyone here with a question?
You know what?
All of our teams
You
can
guys
get
have all
up and
been
ask
a
a question.
great audience. We have one person and one question, please.
Hello, my name is Chris Spencer. I'm a College Diabetes Network Next Gen Fellow, and I actually have two questions, if I may, but I can only ask one if that's necessary.
Go for it.
Go for it.
So, my first question revolves around islet cell replacement. It was mentioned that, how do I say this? It was said that that beta cell function is kind of the singularity. That was the word that was used. Beta cell function is the singular problem with type 1 diabetes, the most pertinent indicator that needs to be fixed. And I'm wondering if, based on the findings of this conference, if that's enough. I learned so much at this conference about how type 1 diabetes is a disease of the whole pancreas. So you see amyloid deposition around para-islet capillary walls. You see a decrease in vascular diameter. You see exocrine tissue degradation, decrease in pancreatic size. How do we improve the more sustainable methods of islet transplantation, like using iPSCs, while maintaining that level of biodiversity?
You're in college?
This is good. This is good.
Okay, we're going to answer this.
We'd love to talk to you afterwards.
And we'll get your second question after we end. But because, Jeremy, do you know what he said?
Yeah, I think you and I could talk a long time about this, but I think, it all starts with the destruction of the beta cell. And from there, everything goes haywire. You lose, amylin production, glucagon goes awry, you have insulin resistance, you have cardiovascular disease. So addressing it with exogenous insulin is not the answer, but replacing these cells is a good place to start. And the question becomes, what cells do you use? Where do you put them? How do you, infuse them? How long do they last? All those kinds of things. That is a very complicated topic. But I will say, if you could offer me, an implant that, was long lasting, certainly did immunosuppression, I think everybody on this panel would take it today. So there's a lot of hope for that, and we're getting there.
Thank you for that question.
Yeah, I just want to
Jeremy's going to be around for the second one.
I just want to make a quick clarification.
Yeah, please.
So I don't think any of us think that insulin deficiency or beta cell dysfunction is the singular problem associated with type 1 diabetes. We think there's a lot more going on with type 1 diabetes that needs to be addressed that can't be addressed just with insulin replacement. So just to kind of clarify that starting part of your question, none of us think that that's the only problem.
Come on up after Spencer. I'm impressed.
Not even me.
Now's a good time to just say
Dr. Polinsky?
thank you all for supporting the organization. Thank you to our panel. And if you feel inclined, we're always looking to help support the organizations. Please enjoy some dessert and coffee and more alcohol if you're not driving. And thank you again. All right.